Are you sick and tired of staring at that strip that someone hands you when you're standing in the room of a patient, looking at ABG going, what the heck is this? What does it mean? Think, brain, think. I think this was me in the early days of my career, and there were several speed bumps that once I got past them, the light bulb went off and I went, oh my God, this is like so simple. Why did I make it complicated? If you are looking to level up your ability to rapidly assess what's happening on ABG and with your patient, this is the video for you. I'm going to share with you a lecture that I provided in my Acute Care Lab membership where we walk through the stepwise approach to ABGs. And that's what you have to do, friends. It doesn't immediately start off with you going out of order and quickly looking at things and looking at how your patient's breathing and giving an answer. You have to learn the stepwise approach. So I am so glad that you are here. If we haven't met yet, my name is Bree. I'm an RN, NP mentor, interview strategist, content creator, and educator. Thanks so much for joining, friends. Okay, we're going to go ahead and get started. Tonight we're talking all about ABGs. And this is meant to be an introduction as well as a deep dive. And what I mean by that is I'm going to review sort of the basics, what you've been taught, the first three steps, pH, PCO2, bicarb, what primary state do we have, and is it compensated or not? But like me, you guys have probably had a lot of lectures like this and then they ended there. But we have to go much, much deeper than that as providers. It is important to determine what's happening on the ABG, but our whole goal is to figure out what we need to do for this patient. And that, if you backtrack, is based on what the most likely diagnosis is. And an ABG, properly interpreted, is just a tool to help you get there. That's all it is. But I want you to be able to approach this very rapidly. When I started, I felt like I spent a lot of time just staring at the strip going, okay, I see two states here, but what came first, the chicken or the egg? And it took a fair amount of time, I won't say how long, to get to a point where I could very, very quickly look at things completely out of order and rapidly assess what's happening and give orders to the bedside staff. But you guys, we have to start with a stepwise approach. So that's what we're going to do tonight. So I have this caveat here. It is fundamentally important that you understand that just because something is red or has an arrow that's abnormal next to it does not mean that it is an abnormal state for this patient. We need to be able to interpret why this abnormal state is existing, because this may in fact be a new normal for this patient. So that is the fundamental basis of what we are teaching about tonight. Here are some references as always. Always want to include the evidence that I've used. Okay, so what information do we need in order to interpret our ABG? Well, I know what you're thinking. I just need an ABG, Brianna. And in part, you're right. Yes, we definitely need an ABG. What we can tell from the ABG is the basic level stuff that you guys are used to. The pH, PCO2, bicarb, base deficit, lactic acid, all that. Beyond that, you may get an ABG or possibly even a VBG to quickly assess what your hemoglobin and your electrolytes are. It is also very helpful for that. You are also going to need a CMP level though, right? You're going to need your most recent metabolic panel. And I know what you're thinking, Brianna, why in the heck do I need that? Valid question. The reason is this: you cannot directly measure both the carbon dioxide level and the bicarb level from arterial blood. One is calculated based on the other, based on the Henderson and Hasselbalch equation. So most modern analyzers choose to calculate the bicarb on the ABG. So your actual measurement of your bicarb level is going to be on your CMP. They're off by a little bit. There are some factors that make it skewed a bit, and there's plenty of data out there that you can look to see the correlation there. I think it's probably more useful if you're looking at a lot of gases over time to see the trends. But in general, you need to be most accurate in interpreting what's happening with your patient, you need the bicarb from your CMP. So when you're looking at your CMP, this is, I don't know if I'm exposing a weakness here, but I guess I'm going to go ahead and do it because possibly this will be helpful to someone else. This bicarb level on your venous metabolic panel is written as CO2, which to me reads carbon dioxide level. And I know it means bicarb. I know that it reflects bicarb, but it took me way too long to fully understand why it means bicarb. And I think this is confusing to a lot of people. What this is actually referring to is the total carbon dioxide level. And the total carbon dioxide level is comprised of 95% bicarb and 5% dissolved carbon dioxide, carbonic acid, and other ions and compounds. So the vast majority of it is bicarb, and that is why we call it bicarb. And I don't know why we don't just write bicarb on their HCO3. It really has a lot more to do with your lab analyzers at your institution and the measurement that they are deriving as a TCO2, which would probably be the proper way to write it to make it a little bit less confusing, but that's just my brain. Now, the other thing I want to point out on here is this. Most of the numbers I'm going to give you tonight are fairly standard across the boards, with the exception of your bicarb level. Your bicarb level, you are going to see teeny tiny variations across the boards, no matter where you get your information from. You really need to base your normal numbers on what your lab analyzer and your institution uses. So I've got 22 to 30. In the literature, you'll see 22 to 26, which is typically actually used when you're interpreting the bicarb level on your ABG. But some analyzers at the hospitals probably do use that range. You'll see some at like 22 to 29. We're just going to stick with the 22 to 30 here. Just know that you're going to need to insert your normal numbers for your institution. It matters. You'll see it in a little bit. The big takeaway here is just CO2, even though it reads carbon dioxide, is actually a reflection of bicarb on your metabolic panel. So let's move on to the bicarb level on your ABG and what it actually is. This is your normal that you'll see in most literature and at most places, 22 to 26. You'll see it here. And okay, so I kind of referred to this already, but these are the reasons why you may see some skewing of the numbers. Like if you look at the bicarb in your metabolic panel versus the bicarb on your ABG, these factors will affect it, okay? Okay, your PCO2 level. So on the ABG, your normal is going to be 35 to 45. This one is pretty standard across the boards. You're going to see it here. And this is telling you the partial pressure of carbon dioxide level. In your mind, replace the word or the letters CO2, the word carbon dioxide level, with acid. If the CO2 level is high, you have a lot of acid. If the CO2 level is low, you have a lack of acid. That made things a little bit easier for me. Hopefully that'll make it easier for you too. Okay, let's just start working through it, and you're going to do it in a stepwise approach in the beginning. Like I said, later on, you're probably going to do it very simultaneously while you are looking at and talking to a patient. You can tell a whole lot about a patient in regards to their carbon dioxide level if they are awake and talking to you and oriented. So you're doing this all simultaneously, but in the beginning, we got to do stepwise, okay? So we start with our pH. And for the purposes of what we're doing here today, you don't care where in the range of 7.35 to 7.45 you fall. You are just looking at 7.40 and which side of that you fall on. This is the Romanoff method. If you are less than 7.4, you have an acidosis. If you are more than 7.40, you have an alkalosis. And that, my friends, is your primary disturbance, period. To then further define what type of acidosis or alkalosis you have, let's start with the carbon dioxide level. This is your respiratory component. Look at how much acid you got with your CO2. If it's greater than 45, you've got a respiratory acidosis. If it's less than 45, if it's less than 35, you've got a respiratory alkalosis. Bicarb, this is your metabolic component. This is the kidney buffering system. Look at the CO2 on the CMP, which we've already talked about. If it is less than 22, you've got a metabolic acidosis. If it is greater than 30 on my analyzer, you're going to replace your normal numbers in here, friends. You've got a metabolic alkalosis. Now, these numbers that are in the middle of the CO2 and the bicarb, those are your literal middle range numbers. If we apply this same theory of looking right in the middle, like the pH of 7.40, we don't care if it's normal or abnormal, just which side it's on, that helps us to determine what's happening with the patient from a primary standpoint and then for a compensation standpoint. So for a compensation standpoint, it's really important to just look at that mid-range number. Right in the middle of our normal carbon dioxide levels is 40. Right in the middle of my specific normals for metabolic bicarb is 26. You're going to want to change those numbers on the metabolic side to what's normal at your institution and find out what the halfway point is. So a little bit later on, we start getting into equations to determine compensation. We're using these numbers, friends. Okay, hold up. Before we move on, this is the key, y'all. This quote, I think I took directly from, I love it because it gets to the bottom line, and that is, what are our goals? We need to determine what the most likely medical diagnosis is. And this helps us to determine what we need to do to fix the underlying problem. It also helps us to determine the severity and what we can do to help them compensate. So all of this just summarizes kind of what I said in the beginning, and that is, this is a tool that you got to dive deep into to interpret what it truly means, so you don't incorrectly interpret what's happening with your patient. This table came from the thoracic article I mentioned in the beginning. I think this can be helpful if you are the kind of person who just needs to print out equations and have them in your pocket ready to get to, and or screenshot them. You can also go to MD-Calc or MediCalc, any medical calculator, and you can plug this stuff in and it will help you determine it. But I think when you're learning ABGs, it's really helpful to know the components that go into these equations, because it gives you a better understanding of what if you know the components of it and in what proportions the components of it are in, you kind of understand a little bit better about what's happening. This is a chart that I made, and it was derived from this Life in the Fast Lane article. And this is the understanding that respiratory conditions can have chronic compensation. It can either be an acute compensation or it can be a chronic compensation. And this is how you go from needing to use one of those equations that you saw on the last slide to being able to do this stuff in your head. It's a substitution of numbers. It's a leap beyond the calculations. So, and these are referring to respiratory conditions. That's a fast-acting process. And if it's been going on for a long time and it's chronic, you will have the kidneys pick up and buffer for it. It just takes time. But again, to help narrow that down, you apply this 1, 2, 3, 4, 5 rule. The 3 just stands for the 3 in the HCO3, so you can take that out. It's really 1, 2, 4, 5. For every 10 millimeter change in the PCO2 from 40 going up, you have a respiratory acidosis. CO2 is acid, right? High acid. Anything above 40, remember that's right in the middle of our mid-range. For every 10 above 40, we expect that the bicarb will buffer and rise from the mid-range, which for me was 26, by a factor of 1. In a chronic state, it'll be a factor of 4. Versus a respiratory alkalosis, for every 10 millimeter drop in the carbon dioxide level from 40 by a factor of 10, you will expect a drop in the bicarb of a factor of 2 and a factor of 5 if it's chronic. That was kind of quickly run over, but you'll see a little bit better on the next slide. Now, this is a busy slide, friends. We are going to spend some time here. I definitely recommend that this is one that you save, that you pause it as we work through it. I've got some examples that hopefully will be helpful to you as well, and work through it as we go through it so it makes better sense to you. But this is where you spend the majority of your time, because you need to figure out how the patient is compensating. So starting with our respiratory problems, respiratory acidosis, PCO2 greater than 40, remember, mid-range, you anticipate that the patient will develop a metabolic alkalosis. And this, for my numbers, would be of more than 26, so a rise in your bicarb level. This is going to happen slowly because the kidneys don't do anything fast. You can have acute compensation and you can have chronic compensation. And this is that chart from the last slide. So again, I'm going to have it there for you to kind of refer to, because everything in this column under patient goal is sort of how you think through equating numbers. For this, you should see this. And this is how you become fast at interpreting things. Under the acute and the chronic sections, these are where I have the equations, and we'll work through it a little more slowly. For this equation, and this comes from the thoracic article that I told you about, it's like 2 slides back. You can print out those equations. This is the equation of what you expect to see the bicarb rising in response to respiratory acidosis. For chronic, it's going to be a factor of 4. You're going to see that these equations are going to very closely mimic the correlations under the patient goal that we're going to do. So what is our goal in a patient with respiratory acidosis? Our goal is to increase how much they're ventilating. They're not blowing off their CO2. Let's do a sample. You have a patient with a PCO2 of 68. For an acute compensation, you would expect for PCO2 greater than 10, you're going to have a rise in bicarb of 1 for each one. So for this one, 68 is, again, we're basing it off of 40. So 68 is over 40 by a factor of 2.8 once you divide it out by 10. And you're going to increase the bicarb by 1 for every one of those. So you should see 26, right? 26 is our bicarb. We're going to add to it because you're going to see a rise in your bicarb. If this patient is acutely compensating for this respiratory acidosis, you should see a metabolic alkalosis with a CO2 on your CMP of 28.8 or higher. For chronic, it's going to be a factor 4-fold of that. So same equation, but the bicarb is going to go up by 4 for every decade. That doesn't make sense. For every 10 over 40, your PCO2 is. And that's going to give you 11.2 points that your bicarb should go up by. And that's going to give you 37.2. So you see the difference, right? In acute compensation state, it's going to go up a little bit, but it's still kind of in that normal range. But once you get to the chronic component, it is really doing the work and it is driving it up pretty high. This is how you work out the equation step by step. 68 minus 40 divided by 10 plus or minus 3, which gives you a correction cofactor range. And that would give you an expected bicarb between 25 and 31, essentially, which is kind of what we're seeing. 28 is right in the middle of 25 and 31. For the chronic side, it would be 4 times 2.3. That's your change in the PCO2 divided by 10, and that's going to give you 11.2. And that would give you an expected bicarb of 37.2, which is exactly what we get. All right, let's move on to respiratory alkalosis. Your PCO2 is less than 40. You have a metabolic acidosis as what you anticipate for your patient to do. This is as well a slow process because the kidneys ain't fast. This is our correlation equation. For every drop of 10, you're going to see a bicarb drop of 2. In the acute. For chronic, it's going to be a factor of 5 times that. Your equation is this, 2 times the change in PCO2 divided by 10, and your chronic is 5 times that, essentially. Our goal is to decrease ventilation. This is somebody who's hyperventilating. We want to slow them down. Okay, so let's do our sample. Let's say we have a respiratory alkalosis. Our patient is blowing off their CO2 down to 21. Our correlation is going to be change in the PCO2, or for every PCO2 drop of 10, which is 40 minus 21, is going to give us 19. Divided by 10 is 1.9. We'll drop our bicarb by 2. So 1.9 times 2 is 3.8. If we run through the equation of that, we get an answer of 3.8. We should see that our bicarb drops by 3.8, and we're going right from that middle. So 26 minus 3.8 equals an expected bicarb of 22.2. For the chronic component, we'll see the same thing, but by a factor of 5 instead of 2, which gives us a number of 9.5. So 26 minus 9.5, 16.5. Okay, let's move on to metabolic acidosis. This is a CO2 on your CMP of less than 26. You anticipate that the patient will develop a respiratory alkalosis and start hyperventilating. So the PCO2 will drop. This is going to happen quickly. Our correlation factor is going to be for every bicarb drop of 1, we will expect that the PCO2 will drop by 1.3. Okay, this is our equation, so our drop in our PCO2. This is Winter's formula, y'all. This is about the only equation in medicine that I have fully committed to memory because I can't remember anything. This is one I highly recommend you memorize. You see metabolic acidosis all the time. The literature actually tells us that respiratory alkalosis is the most common, which makes sense because people hyperventilate. But I feel like I see metabolic acidosis all the time. I think it's probably my bias because metabolic acidosis is one of the scariest to me. Which we could get to in another discussion for another day. But anyways, you need to be able to very, very quickly take your CO2 on your CMP and figure out whether or not this patient is breathing enough. So bicarb times 1.5 plus 8 plus or minus 2, which is your correction factor. The goal here is to make sure they are ventilating very, very well. They need to be breathing a whole lot. These are the people that your bedside staff will call you and say, this patient looks uncomfortable, they're breathing like a freight train. Well, they're probably breathing that way because their infinitely wise body is trying to fix itself. So don't slow it down. Okay, so here's our sample. You've got a 6 on your CMP for your bicarb level. I don't know why that went out of order. I apologize. For your correlation factor, so here, 26 minus 6, 20. We expect that the PCO2 will drop by a factor of 1.3, which would give you 26. And the answer that's going to give you is a PCO2 on your ABG of 14. Here it is written out, and this is with the range. You want that carbon dioxide level to be blown off at least down to somewhere within that range. This patient is doing that. Metabolic alkalosis. So this is CO2 on your CMP of greater than 26. You anticipate the patient will have a respiratory acidosis, which is going to be not much ventilation, so their acid level is going to start to rise. This is going to happen quickly. For bicarb increase of 1, you will anticipate a PCO2 increase of 0.6. Here's your equation. We've already talked about this. Your goal is to reduce your ventilation. Here's a sample. We have a 41 bicarb level on our CMP. This is the factor here for every increase of bicarb over 1. So we have 41 minus 26 gives us 15. Times 0.6 is 9. So you anticipate that your PCO2 should go up by 9 from 40, so you get 49. You need to be aware that if you have a metabolic acidosis, you probably need to investigate whether or not you have a delta gap, which helps you determine between a non-ion gap and an anion gap acidosis, and whether or not you have a mixed acid-base disorder. I'm not going into it in this lecture. It gets a little bit hairier than what I want to get into. Just be aware there is something called a delta gap, and if you're going by the strict letter of the law, you should go all the way down the algorithm and calculate that. But the hot tip here is if you have an elevated anion gap, you have a metabolic acidosis even if the pH is normal. This slide is telling us what our common causes for these derangements are, because ultimately this is what we want to know, right? The ABG is just pointing us in the direction of what is happening. If you have respiratory acidosis, this person is having an issue with ventilation. They're not breathing. It can be an upper airway issue. It can be a lower airway issue. They can be asynchronous with the ventilator. They can have like severe lung disease. We saw this a lot with COVID when our compliance was really poor in our patients and we just couldn't ventilate them anymore. Neurological issues that keep people from breathing. Basically anything that keeps someone from breathing is going to cause a respiratory acidosis. You can have independent or maybe just an adjunctive effect from an increased CO2 production, which you would see in those states. Metabolic acidosis. This is really going to come down to your HAGMA and your NAGMA. Do you have a high anion gap or a normal anion gap? And it's really important. I mean, you guys have probably seen this a million times over, particularly in your patients with AKI. You need to look at your anion gap and see where you're at. I was taught a LARC as the acronym for the HAGMA. You guys probably have heard mud piles. Whatever algorithm you use, just go down that process once you know you have a high anion gap. Non-ion gap, very commonly diarrhea or hyperchloremic acidosis with too much normal saline. You see that a lot. Metabolic alkalosis. This is typically a factor of overdiuresis. You can have hydrogen ion losses from these things that you see there. Hypokalemia is a big factor as well. This slide is really meant to just give you the introduction. This is by no means a complete list. This is just the most common things that I personally feel like we see a lot. Respiratory alkalosis, again, literature tells us this is the most common state, which makes sense. I mean, you think about all the things that make people breathe fast. It's a lot of problems that can happen in the hospital, right? You can have issues where you've improperly set your ventilator, though, and that could certainly be contributing to it. Okay, let's start working through them. This is our first ABG. Hey friends, are you a brand new NP, or perhaps you're an NP student doing an ICU rotation? Are you drowning in the vat of information overload and really struggling to assimilate new info? I got news for you. We have all been there, my friend. To combat that, I'm going to offer this membership site called the Acute Care Lab. I want to show you a little bit about it. Okay, so essentially this is a private membership, so it is a safe space for you to ask questions and get some education without feeling exposed to the public. This is going to be a bi-weekly live lecture format presented via Zoom. It will be an hour to an hour and a half long. You will have the opportunity to ask questions. It will have relevant information shared on a whiteboard with an associated PDF for each one. As you can see here, the first lecture is going to be on shock, which is the most commonest thing you're going to see in the ICU. So we're going to be giving a nice, long, in-depth lecture with live Q&A regarding shock. If you can't attend live, there will be a library of all recorded lectures available to you. And also included in your membership is a list of all of the archived PDFs that have been created for the course, as well as some extra stuff that I think could be beneficial to you. There is a private member forum that's for Q&A where you can submit any question at any point in time, and the group can respond, and I will respond ASAP. Last but certainly not least are going to be all of the exclusive offers that only members will have access to, which includes 25% off new products. And you'll also get free copies of the H&P cheat sheet and the companion after a certain time frame of membership. So I would love it if you would go check out my website at brienp.com to see if this is right for you. Step 1, what is our pH? What side of 7.40 are we on? We are low. Step 2, CO2, carbon dioxide level. We are low. We are 30.7 bicarb level. Again, we're looking at our CMP. I've got it written a fishbone here in the corner as you can see it. The bicarb level is 19, so we are low. What is our disorder? Now, if you remember that respiratory opposite metabolic equal thing that we were taught in the basics, what they're referring to that is the pH and either the CO2 or the bicarb. Which of those two match up with what direction the pH is heading in? So in a respiratory state, the direction of the pH and the PCO2 will be opposite, respiratory opposite. Metabolic state, they will be equal, they'll be the same. So if you just go based on that, you can tell that you have a metabolic acidosis. But beyond that, we need to know if this is compensated. Now, I've taught you to go straight down the middle, right? 7.40, 40, and 26 as that mid-range numbers to help you decide which side of things you're on. But for the purposes of interpreting it, like giving a name to what you're seeing, all you really are looking at is it in the normal range or not? So is our pH in a normal range of 7.35 to 7.45? And it is. So we have a compensated state of metabolic acidosis. But we need to know more than that. We need to know how well the patient is compensating, and that goes back to our equations. So we anticipate with a metabolic acidosis, we will see a respiratory alkalosis. So we should see someone blowing off their carbon dioxide level to a low amount. And this is the equation from that other chart that I shared with you before. This is our Winter's formula. This is your bicarb times 1.5 plus 8 plus or minus 2. You are going to get a range here of 26 to 30. And the question is the patient doing what they need to do to get within that range? Are they hitting that 26 to 30 mark? They're not. So even though they've compensated, something else is happening. Their body's not doing what it needs to do. So what do we want to do to kind of help the situation out? Well, again, our goal in metabolic acidosis is respiratory alkalosis. So this is somebody we want breathing fast. This is the patient that we want to keep breathing. We want them to ventilate. If they're not ventilating well enough, we want to help them do that through the support of CPAP, BiPAP, intubation. This is not the patient that I want to slow down their breathing by giving them a sedative, an opioid, anything that's going to reduce that. If they're already intubated and on a ventilator, you need to look at increasing your minute ventilation. And then you got to look at the underlying problems. Do you have a high or normal anion gap? You may need to do a delta gap if you think you have both. You need to investigate what's causing that and fix that problem. And if you have a normal anion gap, you may be looking at whether or not you need to give this patient some bicarb. Okay, next strip. So which side of 7.40 is our pH? This one's a little tricky. 7.407 by the letter of the law rounds up to 7.41, so we are on the high side. Our PCO2 is 24, it's low. Our bicarb on our fishbone down there is 18, it is low. So because we are within technically normal limits for our pH, we have a compensated respiratory alkalosis. How well are they compensating? Because you can have acute and chronic for respiratory conditions, right? So let's see what our acute compensation would look like. We would expect that the patient will have a metabolic acidosis in response to the respiratory alkalosis. So we should be seeing a drop in our bicarb. And if it's acute, it's a factor of 2 times the change in PCO2 divided by 10, which gives us an expected bicarb of 22.8, which that patient is doing. But have they been doing it just acutely, or could it be chronic? So let's look at the chronic equation. The chronic equation is a factor of 5. So basically the same equation, just multiplied by 5 instead of 2, which would give us an expected bicarb of 18. So the patient is in fact doing that. I put on here that it was acute, but it's actually acute plus chronic. So what is the patient goal? It is met. So what do we want to do? Well, this might be someone that we consider leaving them alone, right? They're doing what they need to do on their own. Or we could also look at conditions in which the patient is asynchronous with a ventilator, whether or not there is something contributing to them over breathing. Although this is such a narrow, 7.407, y'all. Even though you have a low carbon dioxide level, so you have hypocarbia, and it looks a little bit alarming, right? Because it's got a big arrow. It's way outside that quote unquote normal range. The patient's doing just fine. So you really might consider leaving them alone. But if you're looking for other things, you need to look into why the patient is overbreathing. So ventilator issues, all the things that we talked about that cause hyperventilation, stroke, potassium, make sure you've checked your potassium level. Next up. Okay, so which side of 7.40 is our pH? It is low. Our PCO2 is 49, which is high. Our bicarb level is 34, which is high. Respiratory, opposite. Metabolic, equal. We have a respiratory acidosis, and is it compensated or uncompensated? It is compensated because we are still within that normal range for our pH. And how well are they compensating? So here are our equations for our acute process. We expect the patient will develop a metabolic alkalosis, again, hanging on to bicarb to buffer. So the change in PCO2 divided by 10 plus or minus 3 is going to give you a range, 23.9 to 29.9. If it's chronic, I'm going to go ahead and give it away. We expect it's going to be a factor of 4 times that. We anticipate a bicarb level of 30.5, and they are well above that. So they're doing what they need to do. Is the patient goal met? Yeah, it's met. But what do we need to do about them? Well, again, I feel like I say this in all of them, but should we leave them alone? Things are kind of normal. Things are copacetic in their world. Or, particularly if they're chronically compensated, and you go and examine them and there's nothing indicating that they're hypercarbic or something else going on that's complicating the issue. Strictly looking at what's happening on the ABG, they seem to be doing all right. You can also look at the ventilator. Do you have obstruction issues? Is there something driving up a respiratory acidosis that could be contributing to this? CNS issues, whatever is happening that could make them not be ventilating well. Okay, next up. So our pH is high. Our PCO2 is low. Our bicarb level is high. So what disorder do we have? It is a compensated state because the pH is within normal range. It is a metabolic component. We have respiratory opposite, metabolic equal. So we have a metabolic alkalosis. It is compensated. And how well are they compensated? This is our equation. We anticipate that for the rise in PCO2, our bicarb times 0.6 plus 40 is what we anticipate that our hypercarbia or respiratory acidosis, which is what we anticipate should be. And that should be 41.62. So are they meeting that goal? No, they're not. What do we need to do for them? I put this at the top of everyone, right? But most of these are compensated states. So the question is always, should we just leave them alone? For metabolic alkalosis, a common cause of this is over-diuresis. So is this somebody we've been diuresing the heck out of? Have we met our goals for getting volume off? Is this somebody who's hyperventilating? This is somebody that we would anticipate would develop a respiratory acidosis, which is not a lot of breathing. So if they're hyperventilating because there's a secondary process going on, like they're having a procedure done and they're in pain, maybe we need to address that to help them do what they need to do inherently to compensate. Last but not least, our pH is 7.26. It is low. Our PCO2 is 39.5. It is low. Our bicarb is 16. It is also low. So respiratory opposite, metabolic equal, we have an uncompensated metabolic acidosis. How are they doing in their goals? We expect that this is going to be our Winter's equation that we're going to use, right? So bicarb times 1.5 plus 8 plus or minus 2 is going to give us an anticipated carbon dioxide level of 30 to 34. And are they doing that? No, they're not doing that. So this is the person we do need to help, particularly because they are acidotic. The pH is not good. So this is definitely somebody that if the nurse is calling you, telling you that the patient looks like they're in quote unquote respiratory distress, you don't need to stop that respiratory distress. Now granted, you need to go to the bedside and see what they look like. Is there something else going on that is complicating it? But if it's strictly, like say this is a DKA'er, this is somebody who is awake and talking and mentating with no lung conditions, let them breathe. They need to breathe. Don't give them anything that's going to slow that breathing down. If they need more, you might need to augment them by putting them on CPAP or BiPAP. If this is somebody with a gnarly pneumonia that's not breathing well, you might need to just go ahead and intubate them. Then you need to look at the underlying problems. So is there high ion gap, a non-ion gap acidosis? Do your delta gap. Look at whether or not you need to treat whatever the problem is there. If it's a DKA, start your insulin drip. In this patient, they have a sugar of 473. I'd be willing to bet they need an insulin drip. I put this change to LR because if this is somebody you're going to giving a lot of fluids to, like a DKA, you want to give a more balanced solution so that you don't make them more acidotic by driving up that chloride level. And that, my friends, is the end. Thank you so much for joining.